I'll now call upon Dr. Kshitiz Kumar. He will be presenting his case on submacular hematoma. Please go ahead, Kshitiz.
Is my slide visible?
Yeah, please carry on.
So,
yes,
good morning to all. At the outset, I must thank Scientific Committee of AIS and Dr. RN for giving me this opportunity. So, I'm here to present a case of subretinal cocktail mixture with subretinal pneumatic displacement of a whole submacular hemorrhage. So, this is a case of a 67-year-old female patient who is a known pseudophakic, known hypertensive with a best visual acuity of 1/60 with loss of vision. And we can see here that it was there was an old with fresh submacular hematoma. If I may go back to the slide. Yeah. So this is the patient had a vision of 1/60, and she during the lockdown she could not come, and probably it was of more than 3 weeks duration. And we can see a multiple level of subretinal bleed over here. We can see a subretinal bleed here, and then there's a blackish mound of sub-RP bleed with a dehemoglobininized blood, and we can see it very well on the ultra-wide field fundus imaging as well. And moving on to the OCT, so we can see that there's a tall rising PED with a double layer sign, probably PCV, and there's a whole subretinal heme in the neurosensory below the neurosensory retina. And again, the raster image confirms the multiple level of subretinal hemorrhage, and which was quite old in nature, and there was massive amounts of sub-RP hematoma as well. So with this, I move on. The plan was to do a 25 gauge fast planar vitrectomy with a subretinal cocktail injection of ranibizumab 0.1 cc with 0.14 cc of recombinant tissue plasminogen activator, so that the final concentration was not more than 50 micrograms along with air to achieve a subretinal pneumatic displacement. And the plan was to repeat intravitreal ranibizumab if submacular hemorrhage gets displaced. So with this, core vitrectomy was done, followed by TRICORT assisted DVD induction and completion of vitrectomy. And this was followed by staining of the ILM, so that in case there's a blowout, and particularly if there's a foveal blowout, I would do a ILM peeling. And then the 41 gauge subretinal cannula was used. So the site of injection initially I chose was in the area of the dehemoglobinized blood. And as you can see that puffs of old subretinal heme started coming out. So I changed the site, and I could not appreciate that whether the blister was forming or not. So I changed the site to the superior area. And since the volume of the fluid was, which needs to be injected, the cocktail mixture was around 0.7 cc. So I had using it in a titrated and multiple aliquots was using. And at this point, the air escaped out instead of going in the subretinal space, though the blister had enlarged. So I came back again and tried to, now we can see that a fairly good amount of blister had formed. And so the final part was to achieve a subretinal air. So, but the air escaped outside as well as escaped towards the periphery, causing a localized detachment. And this probably happened because the sub-RP mound was so tight that it did not allow the air to collect below the macula, and hence the air followed the path of least resistance towards the periphery as well as regurgitated out. So I did not know what to do, so I just started with the fluid exchange, and thankfully the air retraced back towards the macula so that we could achieve a subretinal pneumatic displacement. And we can see that the air bubble has retraced back towards the hematoma. And this was a post of 10 days. We can, on ultra wide field fundus imaging, we can see that the hemorrhage had gone down, and a beautiful recovery of the macular anatomy was achieved. And this was 2 months post-op with a very good vision recovery. Thank you.
Thank you very much, Kshitiz. Yeah, Dr. Saravanan, please.
Yeah. Just wanted to ask Mahesh sir, what do you think will be the efficacy of TPA in such large RP component blood clots? Sir?
RP usually doesn't seem to penetrate or have much of, because the RP space, sub-RP space is a tight compartment, the blood doesn't seem to move around. So that is the issue. So even if you inject the subretinal space, even if it goes into the sub-RP space, that blood doesn't seem to move around too much. So it's probably continues to remain inoculated. It's usually the subretinal blood which moves.
So you have this technique of injecting a air bubble in the subretinal space. Can you just elaborate on that technique? Sir?
Yeah, it's a previously described technique from Korea, if I remember right. It's the same thing. I think what Dr. Kshitiz had problems was, there are two things which I can imagine, which I think were the problems. One is the retinotomy size enlarged because the movement of the 42 gauge cannula. But the second time, third time, that movement was not much. So I would think probably we went in too deep inside and it probably hit the RPE, or the tip of the cannula was blocked. So we were not able to inject, is what I would think is the issue. So this is a peculiar issue which seems to be the case in his case. What I would nowadays do is use another needle through which I thread the 42 gauge cannula, so the inadvertent movement is minimized. So a little larger bore. Say if I'm using a 23 gauge, a 24 gauge needle is what I use through the cannula, so that the 42 gauge doesn't shift, doesn't move. The tremor is not noticed by doing that. That's another technique which I use nowadays.
Thank you, sir. Vivek, you have any questions?
Yeah, I also wanted to ask Dr. Shanmugam, when faced with such cases, do you have any criteria which you use to decide whether would you use the tissue plasminogen activator? Basically, would you take up for such a big surgery, or you sort of would let go of these cases and leave them alone?
In this case, I would have probably injected intravitreal TPA and a gas alone rather than a surgery, because if you looked at the OCT, there was a very minimal elevation close to the fovea, and the blood was kind of bisecting the fovea, not lifting it. The subretinal hemorrhage was not exactly subfoveal. So in this situation, I would have probably injected gas and the prone position, so it may have shifted it below. But of course, Dr. Kshitiz's surgery was wonderful, and he achieved the end result.
Dr. Naresh, if you're there, like you do a lot of submacular surgeries. Do you have any points to make in this regarding this video?
So in this case, definitely I'll not do submax surgery, because if you see, only half the fovea was covered with the blood, I think. So probably I think this would have been the best choice for this case.
Okay. How often do you use TPA in your practice?
Very rarely, Saravana. Not very often.